the Green Mountain Care Board. And before we get started, I just want to introduce a few people who are here. One has really been a pioneer in the movement towards healthcare reform, and that's Dr. Karen Hine. So Karen, we're really gratified to have been able to spend a few minutes with you before this meeting, and looking forward to spend more time with you.
Thank you.
And the other person... Yes. And the other person I wanted to introduce, Mike, if you could stand up. Representative Mike Hebert.
There's another Mike in it.
Yeah.
Oh,
proud.
It's great to have you here, Mike.
Thank you for coming down. Nice to see you.
Great. It's good to be in the southern part of the state. So with that, I'm going to turn the meeting over to our executive director for her report.
Sure. Well, welcome everybody, and thank you for having us here down in Brattleboro. Is this better, especially with the lawnmower behind me? So let me give you an overview of the meeting and what we're going to do. I'm going to start out with a few words about who the board is and what we do. Then I'm going to turn it over to board member Lunge, who's going to give you a little bit of a background on the all-payer model, because that is essentially what we're doing now. We're very busy with that. And then I will set up the panel discussion and introduce the speakers, and then we'll turn it over to them, and we'll have questions from the board, and we'll also open it up to the public for questions.
So could I just jump in for 1
Sure.
second? So I also wanted to acknowledge Senator Rebecca Ballin, who just came in the room.
Hello, Chairman. How are you?
I'm doing great. It's wonderful to see you.
Nice to see you.
And we've had a great morning in Brattleboro, and you can be proud of your constituency. Really has treated us very nicely.
Wonderful. And we're so glad you're here.
I think back to Susan.
Okay, so just a few words about who the board is and what we do. So many of you may be very familiar with the board, but there may be folks who aren't, so I just want to level set that. So the board was created in 2011 with passage of Act 48. It's an independent board consisting of 5 members. Right now you'll see 4. We had board member Hogan retire at the end of September, so we're awaiting a new appointment of another member from the governor. The appointment process is, there's a broad-based committee that interviews and selects candidates to send on to the governor. The governor then appoints individuals for the board, then the full Senate confirms that individual. The board is independent. It is not part of the administration, the governor's office. It is not part of the legislature. And in my opinion, that I think is one of the strongest, the biggest strength for the board. We're also very transparent. Everything we do must be done in public. We're guided by Vermont open meeting law. And I think, as you'll hear today, we have a great membership to address some of the issues around healthcare. Our mission for the board is to reduce costs while at the same time as maintaining access and high quality care. And we do that through regulating hospital budgets. We approve any kind of insurance rate request, which includes, we review and approve or disapprove those requests. That includes the exchange. We have recently been given the responsibility for accountable care organization oversight. I'm going to really try not to use acronyms today. And the board, we're deep in this process now. The board must review accountable care organization budgets. We also must certify any accountable care organization that is participating in a peer program in the state. And I think that's it, if unless there's anything else the board members want to add, but I think that rounds it up. We have innovated quite a bit in the past, but we're really working on a regulatory basis now. Our plate is very full. but we are, as I think most of you have seen, have done some great work over the last 5 years, and we're looking forward to implementing the all-payer model. And I think I'll turn it over to Robin Lunge now, who's going to give you a few words of background on that, and then we'll turn it over to the telemedicine panel.
Hi, everyone. Thanks for coming out. For those of you who don't know me, I'm Robin Lunge. I'm a member of the Green Mountain Care Board. I've been a member for a little less than a year. I was appointed last November. Also, since we're here, I want to say I'm also a BUHS alumni, class of 1987. So this is my hometown. So as Susan said, the Green Mountain Care Board's charge is really focused around what a lot of people in the healthcare community call the triple aim: improving health, improving quality of care, and controlling costs. And that's really what the so-called all-payer model, which is a wonky term, is really designed to set us off as a state to move in that direction to achieve the triple aim. What the model does, or the agreement with the federal government does, is it sets statewide targets for cost and quality, including population health measures. So the agreement sets a target for the state that Medicare, Medicaid, and commercial spending will become more aligned with the 15-year economic growth in Vermont, which happens to be a 3.5% financial growth trend. So the idea is, historically, healthcare costs grow like this, the economy grows like this. There's obviously a mismatch there. So we're constantly seeing a situation where the state budget, or families, or businesses are always struggling to keep up with those costs because the economy isn't growing at the same rate. So this is a target. It's not a real cap in the sense that money goes away, but it really gives us a goal as a state to work across payers and across provider agencies to move towards this cost target. We also, as a state, agreed to bring our Medicare growth on a per-person basis closer to the national average. So right now we're growing a little faster, but again, it's per person. So Vermont's an aging population, that was taken into consideration, as well as the state has the ability to ensure that when we look at that trend, that we're factoring into the health of our population as well. In terms of the other part of the model, it sets up a target for 3 high-level population health goals, and these are improving access to primary care, reducing deaths due to suicide and drug overdose, and reducing the prevalence and morbidity of chronic disease. And these 3 goals really came out of the work of the Vermont Department of Health's identification of challenging issues in our state. So the idea is, let's try to rally around solving these issues that we know are challenges. In general, Vermont does really well in all the state rankings around having a healthy population, but we know that people have trouble getting in to see primary care docs and or nurses, and that if they're new to an area, that getting a primary care clinician is tough. So that's something we know we got to work on. We, like a lot of other states, we know that we've had trouble around the opiate epidemic. That's something that we as a state need to work on. So those are really the targets and goals that the model sets up. With that, and for us as a board, Susan mentioned we're really busy right now trying to move forward with our role in that model, and our role is as the regulator. So we were given 2 new regulatory responsibilities from the legislature in Act 113 of 2016, and those are to review accountable care organization budgets and to also certify those organizations. Now, an accountable care organization is a group of providers that have come together to create a system of care and delivery and to accept payments in different ways. And it's our job to make sure that we are taking the Act 113 criteria, which include preserving consumer protections, preserving consumer choice of providers, the voluntary nature of the model, and ensure that the implementation follows those principles set forth in law. So we're this fall going to be looking at our first accountable care organization budget. So this is a new process for us. I think we are expecting that we will plow through it and we will learn a lot and we'll do an even better job next year, because the first time you do something, something's going to go wrong, right? So we're going to make sure that we continue to improve. And then we will also then be working on certifications. I think the last thing I would just say to wrap up this piece is the other area that we've been looking at is across our entire regulatory sphere. Because as Susan said, we look at premiums for Vermont insurers. We look at hospital budgets. We're really trying to make sure that we are constantly improving those regulatory processes so that we can follow the money between healthcare, from the healthcare provider level up to the insurance premium level for Vermont consumers. So that's another area that we will continue to work on. So thank you.
So now we're going to move on to the telemedicine panel. I want to thank our panelists for coming together today to talk with us about telemedicine. And we have in the room Dr. Kat McGraw, who is the Chief Medical Officer at Brattleboro Memorial Hospital. To her right is Dr. Mark McGee, who is the Chief Medical Officer at the Brattleboro Retreat. And behind them, on the screen, is Dr. Kevin Curtis. It's very appropriate that we have him Skyping in today. And I hope he doesn't mind if I share this, and he is, let me tell you, is the clinical director for telemedicine at Dartmouth-Hitchcock Connected Care. So he is actually on a telemedicine ER shift right now. Is that right, Dr. Curtis? So you may be called away. And can you hear me?
I can hear you, but unfortunately the audio quality is making it challenging to understand the questions or comments. Sorry, can you hear me okay?
We can hear you fine. We will work on that and see if we can improve that. So what I thought we would do first is, as setting this up, Robin talked about the 3 primary goals of the all-payer model. I asked the panelists to look at the work they're doing in telemedicine and how that would fit into those goals to remind you the improving access to primary care, reducing deaths to suicide and overdose, and to reduce the prevalence and morbidity of chronic disease. I thought I would have, and why don't we start with the folks in the room, to talk about what you're currently doing in your telemedicine work, and then hopefully we'll get Dr. Curtis hooked up so he can hear us better. So I would, either one.
Great. So I just want to thank the Green Mountain Care Board for the opportunity to participate in this discussion, and all the folks here who have joined us. Nice to see some friendly faces from the retreat here, so thanks everybody. So in terms of telehealth, there's a number of different ways that we have developed telehealth opportunities to meet some of our ongoing challenges. And I think there's a tremendous opportunity for us to think about how to use telehealth to address future opportunities and ongoing challenges. And so, as the Chief Medical Officer here at the Brattleboro Retreat, one of the largest and most significant challenges that we've faced is how do we provide access to care of patients who need it. And one of the biggest limiting factors is really physicians and staffing, nursing, social work, et cetera. My domain is obviously to try to build and support the medical staff here to provide the highest quality psychiatric care we can to our patients. And so some of the very specific pragmatic realities that we've faced is recruitment, retention. Not everybody feels the same way as me or other folks in this room. Not everybody wants to live in rural southern Vermont. It's hard to believe. I don't quite understand it myself. But that's a pragmatic reality. Recruiting a psychiatrist nationwide is becoming increasingly challenging and difficult. I think that's actually suggestive of a positive trend, meaning that the expert experience of psychiatrists is finally being valued by the healthcare marketplace, so to speak. So I think it actually bodes well that psychiatrists are in demand and commanding top compensation packages. And at the same time, we're just in a very, very competitive healthcare landscape. And so Another piece of the work that I've done is, that's really important to the work that I do, and I think it has a direct impact on the triple aim, is what some have considered the quadruple aim, and that's really about how do we engage our healthcare staff in meaningful ways to really focus on their satisfaction, because happy, well-supported healthcare professionals provide better quality care, they drive down costs, they really improve the robustness of the healthcare system. So that's always an important consideration when I'm thinking about some of these initiatives. And so we have difficulty recruiting physicians, and so we have looked at telehealth solutions for some of our recruiting issues to treat the patients in our care, in our hospital, in our outpatient services, et cetera. And so we had an opportunity earlier this year. One of our terrific psychiatrists, Dr. Lisa Lambert, she worked with us in a number of different settings. She's just a fantastic psychiatrist, and we really loved having her on our medical staff. She and her family made the difficult and important decision to move away, and they moved to the Boston suburbs. She wanted to stay engaged with us, but the drive was just too onerous for her to be able to do so. And we were looking at potential telehealth solutions for some of our staffing challenges and opportunities, and we proposed a pilot project in which Dr. Lambert would be able to treat our patients on one of our inpatient settings. And we started very small, very slow, and gradual, but based on input we got from patients who were treated by Dr. Lambert, some of the staff that had been involved in that project. I see some of them in this room, and it's really fantastic. There was a lot of staff enthusiasm and support, and the outcome was really encouraging. And so based on the success of that pilot project, we expanded her coverage to a full-time caseload, and we began to look at opportunities for expanding telehealth programming within our own healthcare system. And since then, what we found is that providing telehealth opportunities in a hospital system such as ours really enhances the scope and the span of what we can do in terms of recruitment. And so we've had a very successful recruitment effort. We brought a second full-time telepsychiatrist onto our staff to provide care in our partial hospital program, and by early January, we're poised to add 3 additional full-time members of our medical staff to provide care in our hospital. And so when I think generally about telehealth, I think about the challenges and opportunities that we have, and I think about how it can be used as a tool to really bring providers and patients together, irrespective of the systems. I mean, traditionally, telehealth has often been, you have a sort of hub-based model where you may have a slight abundance of clinical care that then is sort of fed outward. And so what we tried to do is really turn that model on its head and look at where our patients are. Our patients are here, and to bring the providers into where our patients are and the care that they need in the environments that they need it. And so we're really encouraged and optimistic about the successes that we've had thus far. And when I think about telehealth, I really think about its use as a tool to expand access to high quality care where patients are in a timely manner, because otherwise these folks, they're in our hospital, they're getting really high quality care in a system of care that knows them well and that works really well together. The alternative being they might still be in an emergency department, they might still be struggling with addiction or serious mental illness, they might be at home, unable to work, and unable to care for their families or have meaningful engagements with their community. So those are some of the projects that we've been working on internally. And then we also have some projects that Dr. McGraw can talk a little bit about in terms of how we can help address some of the statewide challenges about access to psychiatric care in emergency departments. So many of my colleagues across the state have really struggled with individuals in psychiatric crisis in emergency departments and not having sufficient inpatient bed capacity to move them out of the emergency departments. And oftentimes, they don't have access to appropriate mental health care in the time that they need it, in the place that they need it. And so what we're working on is building up a program, a statewide program in which we can bring our psychiatrists to the patients where they are in the emergency departments in a timely manner, so we can really front-load assessments, front-load the initiation of treatment, front-load the development of a comprehensive treatment plan that's implemented by emergency department staff. We can offer some technical expertise to nursing staff. We can share the knowledge that we have gained over decades, well, centuries of doing this work. share that expertise on the ground where it's most needed in a timely manner, and really help improve the quality of care, improve access, and really help people recover in a timely manner, and therefore decrease the burden of the overall system, whether it's emergency departments, whether it's primary care settings, whether it's inpatient settings, to really try to expand access and really help folks get the care that they need. That's a little overview about some of the things that we're doing, and I'm happy to talk more, but I know Dr. McGraw has a lot of exciting things that they've been working on here at PMH as well.
So I also want to say thank you for this opportunity to talk with you all about what we've been doing with respect to telehealth. Is my microphone working? Okay, great. So I'm the Chief Medical Officer over at Brattleboro Memorial Hospital, and our relationship to telehealth is somewhat different than Dr. McGee's relationship, just by virtue of why we would be choosing to use telehealth solutions. For us, we really struggle to make sure that we are providing appropriate level of care for our patients in this community in our community hospital. We are not a tertiary care hospital, we are not a trauma center, but we are Brattleboro's community hospital, and we need to provide the services that one ought to be able to get locally in your local community hospital. That's very difficult in some ways in our current environment, as Dr. McGee mentioned, with respect to recruiting physicians and clinicians into our community. But it's not just about recruiting them into our community, but just the virtue of our size. We can't necessarily support a full range of the services that we might want to have access to. And also there's some scarcity of clinicians available. We have entered into the telemedicine space in a couple of different areas. After reviewing a lot of available options out there, my real first concern was about getting telemedicine into our emergency department to support emergency and neurologic issues. In particular, I was most worried about getting appropriate intervention for stroke. It really had become really a leading towards the standard of care to have really some stroke specialists looking at the scans and the patients when they come to your emergency department with a stroke. And stroke care is something we should be able to provide to our community here. We did not have routine access to those that kind of a specialist, and so telehealth offered for us the opportunity to be able to get that. After looking at a couple of different programs, we ultimately elected to collaborate with Dartmouth-Hitchcock. And in January, we went live with what is their emergency neurology telehealth program. And what that does for us is it allows patients who come into our emergency department with signs and symptoms of not just stroke, but other acute neurologic problems to be able to get access to really high-quality physician consultative support to help our emergency department physicians make appropriate medical care decisions for our patients. This has had some great impacts for us. First of all, it works well, and so we now are really able to deliver what has become really a standard of care or a best practice. Second of all, it really helps improve the pace in which patients receive that treatment. We don't have to transfer them up to Dartmouth, for example, for them to be able to get that kind of care. And that's particularly in the range of, in the issue with stroke, speed of care is really, really important. And patients are very happy and satisfied with those interactions. You know, you think, how is it going to be to get that care via monitoring? What it is it's actually physically a cart that comes into the room. It has a camera, which is not just your iPhone camera, but in fact has a lot of Zoom features and whatnot that are controlled by the physician on the other side. Kevin can speak to it more adequately, I think, from the user side on his side of it. But and it allows, and it has the screen, and it allows the patient to have an interaction with the clinician on the screen and to do an entire exam, and then that clinician on that end of the screen can look at all the data and the radiology scans, and then have a discussion with the patient and also with the ED physician about what the recommendations are based on what their findings are. Patients like it. I think that the feedback that we've gotten from folks is that they're really happy to have had that specialty care access right there. And, to give you some examples, of the kinds of situations where we use it, where it's been really, really valuable. A young person coming into the hospital with complaints of really crazy changes in their vision. A young person is not somebody you would expect to have a stroke, but in fact, being able to do this kind of a workup with this kind of a specialist helped us uncover that in fact this was unexpectedly a stroke. So it's been a real boon to us on the emergency neurology side. We also recognize that the second area that we really needed services was in the area of psychiatry. And a couple of years ago at this point in time, we started a group that was, that's within this region, looking at what the acute issues for psychiatry care are and how can we better do this as a region. And one of the things that we really identified was that telepsych would be very helpful, that our patients, as you all know, read in the paper, you've heard us talk about in our presentations to the board, all of the issues with patients who have psychiatric needs, who are acutely presenting to our emergency department, need care, and are not being able to adequately get the care, the interventions that they need, and sometimes end up staying in our emergency departments for really prolonged stays. We do not have a psychiatrist on staff. We do not have a 24/7 group of psychiatrists within our hospital staff to be able to address this. So getting telepsychiatry care into this group of patients, we realized would be really important in getting them the care that they needed. We actually moved forward with this in 2 different venues. So we are working with Retreat to set up, based on their progress with the telepsychiatry here within their own organization. We have an agreement and we're working forward with that to be able to enact that. We also chose to go live in September with another vendor as well, which is, again, the Dartmouth group, using a group of psychiatrists that they work with to provide telepsychiatry. That has also been really a tremendous thing for us. Part of it is about access, so folks actually being able to have a consult with a psychiatrist. The patients have been, again, very happy with the services, being able to actually get that attention in the emergency department in that acute circumstance, having that psychiatrist to actually have a consultation with. But it also has provided some other opportunities for us just in terms of access, in that when given the opportunity for a patient to actually have a plan of care and medication recommendations as are potentially appropriate for a patient, while they're waiting for a bed to become available in another setting for them, we're now able to be treating them, not just taking care of their physical needs, but actually being able to treat some of their psychiatric needs as well. And so we have had instances now where patients have improved significantly enough based on that we then can use our telepsychiatry to consult and give us guidance about whether this patient really truly needs any involuntary admissions anymore. And in point of fact, sometimes they don't. And this gives us the ability to take them out of that involuntary status within our state system and move them into the options of other kinds of psychiatric care that would be more appropriate for them at that moment. And that's not something that's been available to us prior. And that enables us to then really help move the whole issue of insufficient acute beds forward by no longer requiring them for some of our patients. Again, as I said, our patients have been really happy. We've had, and it's been interesting to see the kinds of cases that we've been able to do this with, even things that you wouldn't expect. So, for example, a patient coming in who does have a history of some psychiatric issues, does have a history of some complicated neurologic issues, coming in with some mental status changes. How do you tease that apart? Well, being able to have these specialists at our availability means that we are able to tease out that point of fact for this patient it was medication side effects for a medication they were appropriately taking. So really none of what we would have gone, the roads we might have gone down for this patient. So it's really just provided some wonderful opportunities. We have also started to dabble a little bit in some of the more primary care availability. We did make available for our employees who are on our health plan something called Doctor on Demand, which is basically an urgent care kind of thing done by an app on your iPhone. It has not had a high degree of utilization yet, and we're still playing with how to increase that. But again, that's the kind of telehealth that allows somebody from their home to be able to call in and say, you know, I got this sore throat, I'm not sure what to do. What do you think, I need care? Should I go in and actually get a throat swab or not? And you know, and if antibiotics are appropriate, they can prescribe those. And so, it has not hit prime time in terms of the volume of use of that, but it has had some good success as well.
Great. So, Dr. Curtis, can you hear us?
I can. Can you hear me okay?
We can hear you great. So we're going to turn it over to you now.
Yeah, my pleasure. Thanks for having me. Sorry I can't be there in person. I'm happy to be there. I'm an ED doc by trade. I'm the medical director of our Dartmouth telehealth service lines, and I continue to also serve as the medical director specifically for our tele-emergency and tele-urgent care services. So I guess as far as access and workforce, I think everything that we are trying to accomplish is in line with, as you've heard, trying to help with that sometimes supply and demand mismatch and also the workforce challenges. So as we think about what we're trying to do as far as an overall mission, it's to help deliver outstanding healthcare to the region independent of patient location. And that's, for us, always going to be with a strong rural focus. And the other thing that is important that you've already heard about is that we don't really think about telemedicine as a medical specialty, but just as an option in the toolbox of ways to deliver care that sometimes could be the solution. As far as how we've gone about doing that, our first phase of telehealth, as you've heard some of from Dr. McGee and Dr. McGraw, has been focusing primarily on the acute care needs in the region. And so when we reached out, we identified acute care services as an area, as you've heard, where there was both a significant demand that didn't always align with local supply, and for which in some cases there were large geographical gaps or travel issues. So the service lines that we currently offer in the acute care space, you've heard about telepsychiatry and teleneurology. We also do tele-emergency, we do tele-ICU, we do telepharmacy, and we also do a little different version of kind of tele-urgent care in which our providers deliver backup to advanced practice providers providing urgent care directly when they are looking for additional support, questions, and help. And I think how that has helped in quadruple aim standpoint, some of which you've heard, but for example, if talk about a couple that haven't been mentioned yet, in, for example, the tele-ED space, there are certainly, as we know in emergency departments, there are wide fluctuations in patient volume, patient acuity, and complexity. And so by being available remotely, we can support the local team in whatever way that they need and can help and kind of bring our level 1 trauma center in a way into the bedside to help. In the ICU space, there is both a shortage, significant shortage nationally in intensivists, and increasing demand for a variety of reasons, including the increased mean age in the country. So we have the opportunity to bring that expertise to local hospitals and again, allow many more patients to stay close to home with the same outcome or better as if they had been transferred. I think another piece of that just is the way that we view delivering the service is not to design a service and bring it exactly as is, but to identify gaps or needs of a community or a local health system or a hospital or a group of providers and say, how could we help you address those needs and how could we do it in a way that again allows more people to stay close to home. The last thing that I'll just point out is even though our focus in what we would call our first phase has been highly on the acute care delivery, we also have looked into and are working in spaces of patient services and management of chronic diseases, such as we have a chronic kidney disease telehealth service that brings nephrologists to communities to help people with chronic kidney disease. We have a fairly robust inflammatory bowel disease telehealth service that extends certainly throughout New Hampshire and into Vermont, but also into Maine, that lets a lot of people get that expertise without having to travel. And we also have telehealth at Cedar Crest Center for Children with Disabilities, where we provide a whole bunch of specialty services to children there with chronic diseases that both, again, allows them not to have to travel, which is a challenge both for inconvenience and for them to have to travel, and still brings our specialists to them. So a little bit of a whirlwind summary of some of what we're trying to do, and I look forward to whatever questions folks have.
Well, were we gonna have the board questions first and then we'll open it up to the public? Does that work, Kevin?
Yeah, but I mean, if he has a pressing question,
I
go
can
for
wait,
it.
by all
No, go
means.
ahead, go ahead, go ahead.
Just speak up.
Hi, my name is Pete Novick. I'm a resident of South Dufane. I have two questions. Under all payer, for the telemedicine you're speaking about, are you constrained to bring in only people from existing ACOs or to be ACOs into the population of those who are supporting these telemedicine initiatives? Or could you go down to Cooley Dick and bring in the support from there, or bring in support even from someplace further away? Or are you constrained to look within the 13 hospitals, you know, for which the board's responsible? Or can you go to Mass General or that kind of thing to get that support?
I think what you're asking is, and correct me if I'm wrong, but I think what you're asking is if we're thinking of creating new telehealth approaches or new lines of service that need telehealth, can we go outside of Vermont for those clinicians?
Can you go outside of what's going to be the all-payer model, which will include ACOs that are attributed to the umbrella organization, all-payer in Vermont? What that means is, if all-payer is going to capture costs that are related to, this is more of a question for you guys, if all-payer is going to capture costs that are more related to achieving an understanding and the granularity of the total cost to the population, then, and if you're going outside of the ACO organizations that are set up and that you monitor to provide some of the support, those cost figures are an anomaly to your model. And therefore, you have to somehow figure out how you put that into your equation so that you know that these outlying expenses aren't really part of your core costs. You have to pay the bill, or the hospital has to pay the bill, but they're not part of the ACO.
So as you can see, what you've heard this morning, this afternoon already, is that this has been working outside of the ACO already. And this panel isn't meant to be brought together just to show what's possible inside of an ACO. But as we move towards population health, the deal that was signed with the federal government looks at the overall population in Vermont, just those, not just those members of the ACO.
Right.
And so by 2022, we have to be at 0.2% less than the national trend rate as far as the growth in costs. And so I think that your question might be that you have concerns that the ACO will have utter control, and I don't see it as that way, but am I understanding your question correctly?
No, I wasn't, I was just concerned with, it seemed to me that the ACOs that are supporting all payer, that's a sort of a known quantity, right?
Yep.
We know who they are, where they are, we know who's participating. So if you find somebody that opens a telemedicine type business in Cincinnati that offers these kinds of services, but they're not part of your ACO, but you use them,
Right.
how do you
Yeah,
reconcile?
I can take that. So patients always get to choose where they're going to go, regardless of whether they're in the ACO or not in the ACO. This is not a restriction about where patients choose. And right now, even though we use the Dartmouth Center for Telehealth to provide our telemedicine solutions, you know, for example, for neurology, some of those neurologists are up at Dartmouth, and some of them are in DC or there.
So they could be sitting anywhere in the Northeast United States with the headquarters of the partner organization being in Virginia.
Right, right.
I got it.
And either way, you know, whether they're here in this state or elsewhere, you know, there needs to be some exchange to pay for the cost of that care.
Right.
And just the same as somebody who maybe has some very rare cancer that needs to go down to Boston for their care down there. That still happens and still will continue to happen.
Thank you.
I think one of the things you've picked up on is kind of one of the complexities of the ACO model, which is someone that's in that model may go down to Florida for 6 months and get their care there, and it's
Right.
still going to be paid for it will still be paid for out of that, you know, ACO budget. But as we're reviewing the budgets this week and looking at that forecasting, some of that is not as predictable.
Yeah.
But certainly the patient has the choice.
Thank you.
So do I understand that if, for example, I come to BMH, I'm in the ER, and I have a consultation with a specialist from Dartmouth-Hitchcock, Medicare pays for that consultation directly? I'm sorry.
And before you answer the question, if each person could just identify themselves when they ask the question so that we have a good record.
I'm Sue Brad, I'm a retired nurse.
Great to see you.
Interested.
So a telehealth consult is like a consult of any other sort. So if you come into the emergency department with a broken leg and you are seen by a broken arm that doesn't need surgery at that point in time, and you're seen by the orthopedic surgeon, they're doing a consult for you. So that would be billed. Telehealth provides the option for that same kind of structure. And we have had to wrestle through the legislature the ability to do that kind of billing, to say, this is a consult, it's not a person, you know, that you can touch, but we are figuring out ways to adequately do an exam, so there really is an exam, there is the conversation to make it be a real true consult. And so therefore it should be able to be billed similarly. And then therefore paid similarly. And, you know, quite honestly, at the moment, we're still working out some of the details of that to make that be true. So if in fact you've come to the hospital and had a telehealth consult, you probably haven't seen that bill in that way. But it's really, the intent is to have it be as similar to in-person visits as we can make that.
And so my other question would be then, what about liability?
So any of our telehealth consultants that we use, and Kevin, feel free to jump in because this does really apply to you all as well.
I'm only catching part of the question, sorry.
Oh, that's right. Every one of those individuals is credentialed and a member of our medical staff. Even if they're in DC or wherever, they have to have a Vermont license, they have to have malpractice, they go through our credentialing process so that we, and you know, with quality assurances and all of that, so we really have vetted them. It's not just a random somebody on the other end of that camera.
So you can have the same confidence that you have in that telehealth provider that you would have as with Dr. McGraw and any of the other members of their medical staff, because the credentialing process is identical.
Right.
So, I mean, I heard a couple of questions that I'm happy to jump in, and at least the parts I heard, if it's helpful. So one is, as far as the kind of ACO Vermont, the concept in Vermont, and how do we continue to capture people that will get some of their care outside the region. I think on the one hand, and I think this is what I heard, that would be a situation where I wouldn't think of telemedicine as a specialty, but again, as another way to deliver care. So probably that issue of how do we best provide the majority of care for people in that group should be solved within telemedicine, but also within the greater question of best addressing that. I don't think telemedicine will be unique in that space. I think the opportunity it does provide is if there is care in the region that occurs 6 months and 1 day of the year, and the other 5 months and 29 days is occurring where it's warmer in the winter, then if we set up a telemedicine opportunity, then some of that care can be still provided from a Vermont provider while the person is in Florida. So that is a new opportunity for outpatient visits to occur and still be more easily captured. I think that in the, as we've said, in the larger triple or quadruple aim piece, that there are a number of telehealth services that fairly clearly give the same or better outcomes for the same or lower costs. So when we're thinking about the total cost of care, and even though it is the most invasive, for example, the presence of tele-ICU pretty clearly in the country shows decreased mortality, decreased morbidity, decreased days on a ventilator, et cetera. So when we're thinking about total costs of care, the presence of that, as much as it exists, could enhance outcomes and costs. Similar for, as Dr. McGraw said, the use of teleneurologists and to increase the appropriate use of TPA, which has been shown to improve outcomes. So I think it does have the opportunity to increase capture people who we want to be accountable for their costs, but fortunately at the same time enhancing outcomes, and then, as you've heard from both Dr. McGee and Dr. McGraw, doing it in a way that not only aligns with workforce needs, but probably helps with provider satisfaction and patient and family satisfaction as well.
Okay, are there other questions or comments? Yes, go ahead.
How does the what do we call it? Telehealth. Interface with the next generation aspects of the all-payer model? From some things that I've read that have been kind of confusing to me, makes it appear that this is kind of a big aspect of the all-payer model. But maybe I just have that all wrong. Anyone?
Do you want me to?
I have some thoughts on that if that's useful. So, and I'm sorry, what did you say your name was?
Sue.
Sue. Hi, Sue.
And I'm a retired nurse.
Okay, well, thank you for your service as a nurse.
Yeah.
Are you sure you don't want to come back to work? So, Sue, a really important question. And so when we think about the all-payer model, I think when I first heard about the all-payer model, when Governor Shumlin came here in the recent past to describe it, I think some of the things that I was most excited about as a psychiatrist in particular, and somebody who's really invested in providing high-quality primary care, were the three aims. So increasing access to primary care, decreasing the burden of psychiatric illness, suicide, death by overdose, and improving outcomes for chronic disease management. And as a medical student and a resident at the University of Vermont, I'm always reminded of one of my teachers and mentors, Dr. Jim Hudjak, who's a child psychiatrist, very actively involved in primary prevention of psychiatric illness. And his words of wisdom were, without mental health, you have no health. And so I think the all-payer model, I think, really gets that, in that it's articulated right there in the initial goals of that system. And it's about integrating mental health and regular primary care health in a really meaningful way. One of the things that for several years I've been interested in is finding ways to really forge those connections between primary care and psychiatric care, because I see them all as integrated. I mean, the body is really just there to keep the brain alive, in my view. And maybe that's the provincial view of a psychiatrist and a neuroscientist, but I think it's the most important organ system in our body. Few would argue with that fact. And your heart is a pump that keeps blood going to your brain. And not to disparage or diminish the value of cardiology or anyone else, and my esteemed internist colleague, but seriously, I mean, I think that's one of the things that I'm very optimistic about is, again, the healthcare marketplace is catching up and valuing what psychiatry and mental health providers have to offer that discussion, whereas they used to be, on the other part of town or in a very isolated sort of, small part of the hospital or healthcare system. That being said, there are very, very outstanding models of integrating those two models. And there's a model, it's called collaborative care model of primary care psychiatry. And what that is connecting your primary care provider that you go to for all of your healthcare needs and allowing a partnership with your primary care provider and a consulting psychiatrist, less so for the psychiatrist to see you if you have a psychiatric need, but more to help support the primary care provider in feeling more skilled, more savvy, a little bit more expert in managing their aspect of your care. And one of the things when I began to learn about this model, one, I was impressed with the outcomes. Not only does it improve the outcomes for psychiatric treatment, improving the quality of psychiatric care, but it improves general health outcomes, because if you're less depressed, less anxious, using fewer substances, your other healthcare concerns are going to improve. You're going to feel better, you're going to have more energy, you're going to exercise better, have better relationships. All aspects of your life are going to improve, particularly, heart disease, your blood pressure, all of those things. And so what I was so impressed with this model is that the outcomes are great, the cost savings are really quite substantial. And I was really interested in seeing how we might be able to partner with some of our friends in primary care in the area to try to build up this model. The thing we kept bumping into is how do you pay for it? Because you can't bill Medicare for a collaborative consultation discussion between a psychiatrist and a physician. At least currently, at that time, you weren't able to do so. And you can't bill the insurance company to pay for that. And so the only way, the way the research was supported was from grants and foundations and some research dollars that proved that as a viable and really outstanding model. I think where all payer comes in is it creates the funding and financing infrastructure to allow that to happen. Because it's not about a point of contact where you're seeing your doctor and then the provider has to submit a bill for that to the insurance company. It's really about the motivation to keep everybody as healthy as they possibly can. And so it really eliminates all of those logistical challenges to doing so. And so that was one of the things that I was so excited when I heard about this particular funding model, is that it really creates an opportunity for very innovative care models to be implemented and to be supported and really improve all aspects of individual patient care and individual population care.
Well, so do I understand that the next generation, you can shut me up. Or you can try. They've been trying for years. No, the next generation of the all-payer model, is that the phase in which Medicare people will be moved into the all-payer model? Medicare is what I'm
So the next generation accountable care organization model is a Medicare model. That name comes from a Medicare model that CMS is actually opening up across the country. Right. So where our Vermont version comes in is in 2019, we have the opportunity to tweak some of the rules of that Medicare payment model to make it work better for Vermont. We may do that, we may not do that. In 2018, it's the exact same Medicare model that is available in other states. So, but in 2018 is when that particular model starts with OneCare Vermont, which is the ACO that has been applied and been accepted by Medicare to participate in that national model.
Right. And so is it anticipated that the federal government is buying into paying for the telemedicine?
So as was noted, where it allows for more flexibility is it's no longer, the payment model is no longer, I pay you for a Band-Aid and then I pay you for a consult and then I pay you for an X-ray and then I pay you for the next little piece of service that's provided. It's more of a per person monthly prepayment to, in this case, to a hospital to take care of that patient. There's still some reporting so that Medicare can track whether, you know, you're spending more or less than you would have otherwise spent, but that's really the concept, that's how they have put forth that model on a national basis.
And Robin, did you want to touch on the telemedicine waiver that we got through the OMPAY?
That's great, yeah.
That might be a good.
Yeah, so thank you, Susan, for reminding me of that. So part of the national next generation model is it allows for a change in the rules around telemedicine for Medicare to allow for more flexibility. So that is a piece that's available nationally in the model, and if we find that there are some implementation challenges, then that may be an area that we could, in 2019, say, okay, we want to do the credentialing slightly differently so that it works with the way that we do it now in Vermont, or something like that. I mean, I'm using that as sort of a fake example because I don't know that we'll ask for that, but we have this opportunity to, for 2019, tweak some of those rules if needed to make them work better for how we do things in Vermont. Thanks, Susan.
So I'm going to do a little Phil Donahue because I saw Susan's hand up next. And I want to make sure that Dr. Curtis is actually hearing. Is he still there?
I think we might have lost him.
Oh.
There was a chance that he had
Trick or
another.
treat.
There he is. Oh, he's back.
Treat.
Okay, so Susan, if you could use the mic, start by introducing yourself.
Thank you. My name is Susan Aronoff. I am a Senior Policy Planning Analyst for the Vermont Developmental Disabilities Council. And very happy to see all these familiar faces in Brattleboro. I think this is great. I had a follow-up question. I guess this is more for the board than for the Telemedicine Panel, about the Medicare Next Gen ACO enhanced benefits or changes in benefits for a typical Medicare member might receive certain benefits, but if they're in a state that has a next generation Medicare ACO, then there's an opportunity to receive what are sometimes called enhanced benefits, 3 or so different things. I think there's some confusion in Vermont, and I was wondering if you could just speak to this about whether or not those benefits, including the telemed one, or not having to stay in a hospital for 3 nights before going to a nursing home, are those going to be available for all Medicare beneficiaries in Vermont, or only Medicare beneficiaries attributed to a participating ACO? When and how will the beneficiaries know? And how, especially with respect to the 3-day stay waiver, is that being rolled out and being publicized? And is it going to change at some point? Will it first be, if you're an attributed life to an ACO, you get to go skip the hospital stay and go to a nursing home? Or in 2022, it'll be every Medicare beneficiary? There's a lot of misinformation out there, so I'd love to hear it straight from the real people.
Thanks, Susan. So it's my understanding, and we will correct this if I get this wrong, so Susan will know what I'm saying, that under the Medicare Next Generation ACO model, Medicare only approves those enhanced benefits for attributed patients to an ACO. So from a legal perspective, they are providing those extra benefits because this is in an approved model that's not regular Medicare. So I don't know if they would ever approve providing those enhanced benefits outside of the attributed lives. I tend to think not, because legally I don't think they necessarily could. I think that their legal ability to provide those extra things is because it's approved as part of a new payment model. So we'll double check on that, but I think my best guess is that that will only be for attributed lives in perpetuity. And that's certainly the case in 2018 when we're in the national model. In terms of the when and how will the beneficiary know, I think that goes back to the ways that Medicare allows or requires the ACO to provide notice. And again, that's something that Medicare, that's not something that we as a state have control over. That's done in the same way that Medicare does it any place else. And my recollection is that for the Next Generation program, there is a notice mailed to the beneficiary. For the Shared Savings program, it's done by posting a notice in the office. And so that would be the way that people get educated about that, although I think the reality is they'd probably be educated about that in making decisions about their care with their clinician, as a practical matter.
So, other questions or comments?
Are we in general questions now? Or
Yes.
I think we are.
This is great. You guys
Just
have great
introduce
ones.
yourself. And
Thank you. Kathy Bolton, Executive Director of the Vermont Program for Quality in Healthcare. And I'd just like to make a few comments and share some information. My small organization is in a cooperative agreement with Maine and New Hampshire, 3 quality organizations together, in addition to the area health education centers, the AHECs, across the 3 states. For a grant award from the HRSA administration, which is a federal funding program that is supporting the development of a regional telehealth hub to be coordinated across the 3 states. Dr. McGee, Dr. McGraw, Dr. Curtis will probably all be involved in that work, and we're very thankful for their volunteerism as we get this effort underway. So I'm very pleased to share today. We're literally in our forming stages of this great work, and hope to be able to come back to the board with progress reports as we continue down this path. But I think what maybe Sue to address some of the comments that you made, what I see the opportunities through our award funding is to reform some of the delivery system opportunities. And I think it was Dr. Curtis said, to have the right tools available at the bedside at the right time. That's what this is, system delivery reform, and it touches on payment reform, but all the APM Next Gen, how we get paid, is a little bit of a side path to the actual work of putting experts right alongside your side if you have the need across the region. And really to coordinate, so we're not duplicating or wasting or having gaps of service, so that all the services are really more available to all the residents in the northern New England region. So we're very excited to be able to share this information, and as I said, we'll continue with progress reports as we keep moving down the path, and I'm very happy to share the information, so thank you.
Thank you. Here we go.
Hello, my name is Pete Novick again. I didn't change that yet. I'll try. It's trick or treat night, so I still got to go buy candy. This is a money question. It's a little complicated. If you don't mind, I've made a handout for you guys. Would you like a handout?
Sure.
I type everything in 16 pitch. I only brought enough copies for the board. And I think I got the right number. But you mind if I stand?
because it's a, well, that's
No,
all
that's
good. So the money question has to do with the transition from a legacy fee-for-service system to all-payer. And I'm not an all-payer expert, and I want to sort of become more of an all-payer expert, which is really why I came here today. I'm learning a lot fast. Under the legacy system, Pete goes to Grace Cottage Hospital, sees his provider, and she says, let's get an x-ray and let's get some blood work and see what's going on. So that's an office visit, x-ray, blood work. And Grace Cottage Billing Department bills Medicare, since I'm in original Medicare. That's pretty simple so far. Medicare has what's called a crossover agreement, automatic method of alerting the secondary payer, which in this case is another federal program called TRICARE, which is a program, not an insurance program, but it is a benefit Congress provides to active duty military and retired military. And then the TRICARE for Life office that's administered by Wisconsin Physician Services pays the copay to Medicare. And since Grace Cottage Hospital accepts Medicare assignment and they accept TRICARE assignment, all those numbers are known. And then there aren't any other out-of-pocket expenses at that juncture if both services, if the services provided are covered by both Medicare and TRICARE. In January, when you transition to the all-payer model and roll through the ACO, my understanding is that there are periodic payments made into the ACO to take the place of the fee-for-service. Is that correct?
So it depends on, first of all, whether or not you're attributed to the ACO.
I would be attributed as a Medicare, original Medicare person, right?
No.
With a PCM.
Only if your primary care physician joins the ACO, which is probably only happening if the hospital is also joining the ACO. Right. So in your example, we know for 2018, Grace Cottage is not a member of the ACO.
Okay, well let's assume that they are, just because it makes the question a little more interesting and the answer is probably more challenging. So when you go to all payer and you are in now a hospital with a provider that is part of an ACO model, but you're in the all payer and you're out of fee for service. So you do the same thing, you go to your provider, it's now middle of 2018, you get an office visit, an x-ray, and some blood work, and the billing department in the hospital that is part of an ACO sends the bill to Medicare. But they're not really sending a bill to Medicare, but they have to somehow provide the accounting to Medicare so Medicare can do the tally, so they can do the quarterly or semi-annual or annual roll-ups to determine whether you're high or low, whether you missed the mark or not. So I got that part. The question is, when Medicare needs to hand off to a co-payer, either a private insurance or in this case another government program that's not captured within the ACO framework, what numbers do they send them? So that the secondary payer knows what to pay in the copay to the provider. I looked through your website, I spent 4 hours on it yesterday. Until I had to have a drink. Sorry, not really.
Just one.
I mean, that's not a nice remark. Trick or treat, trick or treat. So, but I couldn't find an answer to that question. But that's a very important question, I think, not just for my situation, but thousands, tens of thousands of people have that kind of model. They have a primary payer and a secondary payer, and many of those will not be in the same state. They'll be part of a different government organization. And somehow there needs to be some cross-pollination so that the numbers that Grace Cottage Hospital or Dartmouth-Hitchcock or whoever sends to get paid for Medicare, in this case there'll just be an accounting entry made, but how does Medicare then alert the secondary payer and what numbers do they provide them? So I'll shut up there.
So we can double check. So this is a Medicare operations issue, not a Green Mountain Care Board regulatory issue, but we can ask Medicare because we have meetings with their folks about the operational details. But my understanding is that for the co-payments do not change for the beneficiary. So the provider will do a claim with as if it were fee-for-service, but there will be a flag on that claim at Medicare so they know that it's an attributed patient. They, just like fee-for-service, they would still notify TRICARE in the same way. TRICARE would pay the same way. And I think that's how Medicare operationalizes it.
Two issues. I mentioned this when Governor Shumlin was down here whenever he was down here, that there doesn't seem to be on the Green Mountain Care Board website process documents that are these nice flow charts with the little squares and triangles and little, those kinds of process documents that all of us understand how to use, and put them right on the front of the website so that people can see, oh, this is my situation, here I am. For instance, your comment about whether your hospital and the individual provider in that hospital are or aren't part of an ACO, that's huge to know for that transition year in 2018. And I think that kind of data, for the people who are searching for answers, they'll go find that on their own if it's there, and if it's only one layer deep, you know what I mean?
So I think you've raised some really good questions, and my guess is that TRICARE people are not going to be treated any differently than they're treated today. But we have our first ACO, well, actually our second ACO budget hearing coming up this week. And we will specifically ask them how the person situated in the situation that you described, because I want to make sure, just like you want to make sure, that what I believe to be true is actually true. And as far as the website, I can tell you that all of us share your frustration. We are trying very hard to improve the website, to make it more user-friendly. And Connor Kennedy, who's at the back of the room, is part of the team trying to figure out how to make that website better. So I'm sure that he's getting the message that we continue to get, that despite our best efforts, it's not the most user-friendly site. And we're working on that, and we're trying to make it better.
The issue with TRICARE is not so much that it's just one of many federal programs, but there's specific statutory language that talks to state systems that change the healthcare system cannot preempt healthcare, and that's in the federal code.
Yeah,
so
and we will be involved in that operational piece. So the state doesn't start operating any of this. So it's still Medicare and TRICARE operating your coverage.
Right.
So the nice flow charts that you're talking about, those would be developed by Medicare and TRICARE, not us, because we're not a payer. They still remain the payer.
Right, but you're the regulatory authority, and that makes it.
We regulate the ACO.
Yes. So I think you really do have a really good question. We'll get the answer. Okay.
Yeah.
I'm patient.
Yeah. Other questions or comments?
I'm an attributable patient.
Kevin out. So, and I forgot to introduce this person at the start of the meeting, so my apologies, but the person with his hand up is our healthcare advocate for the state of Vermont, Mike Fisher. And he really is the person who is every day working to improve the lives of consumers of healthcare in the state.
Thank you for the introduction. Yes, Mike Fisher, healthcare advocate, but with your permission, I'd love to ask a question about telemedicine, not as a citizen,
That'd be great.
not as the healthcare advocate, because I'm not sure that my healthcare advocate team agrees with me. So this is just Mike Fisher, president of Lincoln. I think telemedicine has a potential to provide for an improvement in access to care in many situations that I wouldn't argue with, and that I think are really good. I'm a 27-year frontline social worker providing home visits to in the early childhood context. And I believe in my heart that people get better in relationship. And I believe in my heart that the gold standard of care is person to person. Again, I'm not afraid of technology. I think technology is really useful and it has its place, but I don't think it's the gold standard. If we need to bring in an expert who's not present in Vermont to consult with a provider, great. If we have an individual who has an ongoing relationship with the provider, where the provider wants to do some of that care over a telemedicine interface, great, no complaints. But I do have a concern as we have a lack of providers and this newly available tool of telemedicine, that it will take the pressure off of us of making sure we have, I'll just say, primary care providers in rural Vermont. And so that's my round the boat, working up to a question. I wonder whether the panelists share any of that concern or have contemplated maybe a negative side to this new tool.
I'll speak to that one. I share your concern around the primary care relationship, and as we know here in Brattleboro, we are, with several retirements of our primary care clinicians, we have a shortage of primary care, and at our hospital, we have not been, burning up the phone to get the telehealth primary care system up and rolling. We have been burning the phone with trying to recruit really high-quality primary care clinicians, whether it's MDs, nurse practitioners, or PAs. And in fact, we've been, getting a lot of success with that, with very intensive efforts. And I think that this community will reap the benefit of that over time. It takes time for, the whole process to really go start to finish. I think that one of the things, as you mentioned in the midst of your prelude to the conversation, is there opportunity for primary care, somebody that you have a relationship with already, to have telehealth as an augmented way of providing care? And I think that that's something that we haven't done yet. I think it's certainly with Dartmouth and specialty care, I think that you are doing some of that. And really what that does then is provides the benefit for the patient, the convenience of not having to do extensive travel, still being able to have the really up-to-date, appropriate, whether it's specialty care or primary care that they want, with the relationship that they have. So I don't think that we're we're in New England. Realistically, we're not in. While we are a rural state, we are not in a vastly sparsely populated state. And while we have a shortage of primary cares, it's not that we are without primary cares. And so I don't think we're headed, certainly not at Brattleboro Memorial, but we take that as part of our mission as a community hospital to really have adequate primary care for folks. So we're not on road to turn that into a completely telehealth solution, although there may be some circumstances in other areas where that might be more appropriate. But I think over time you'll see more of a mix, but we're certainly working very hard to recruit in-person primary care physicians.
And I can address your question, Mike. And so thanks for the thoughtful question. And it's something that I've given a great deal of thought to. And as somebody who was a therapist before going to medicine, I really understand the immediacy and the primacy of the relationship. And I think one of the things that that was reinforced in my education and training is, again, the primacy of that relationship that occurs in that therapeutic exchange. And that being said, as a clinician, I have a lot of apprehension about, similar to your describing, is the method for conveying that care, delivering that care, is that going to impede the ability to form that relationship? And what I've discovered, both in providing telemedicine personally, supervising those who do so, and speaking with people who have received telemedicine care, and extensively researching and reviewing the literature on telehealth and telemedicine, telepsychiatry in particular, it's really the quality of that relationship remains central. So if you can convey and really relate to somebody and connect with somebody and compassionately and empathically really try to understand what they're struggling with, you can do that in person. You can translate that into a telehealth setting. And so that is that's a fairly universal reality. If you're gonna be a bad therapist in person, you're gonna be a bad teletherapist. I mean, that's undeniable. Interestingly, your apprehension is one that many of us in terms of clinicians experience as well. And so what the literature shows is the individuals in that exchange that are most apprehensive are usually the providers themselves, until they have some experience, because they worry, just like you, that something's gonna be missing. And so I've supervised a lot of new telepsychiatrists who are kind of like, I'm not sure if this is going to work. And then they do it. They're like, oh, okay, this can work. This really works really quite well. Just as an anecdote, I was covering one of our uniform service program, which is a specialized program for first responders, firefighters, and police officers. And someone had come from our inpatient service, and they'd spent a few days, and they'd seen Dr. Lambert, who I'd referenced before. And I said, oh, how was it? I was doing a little quality control, but also I wanted to just, kind of engage with this fella, and he just lit up. He said it was amazing. It was like the Jetsons, and that'll tell you about how old he was. A little older than I am, because I grew up with the Jetsons, and it was a space age thing. And so, I think that apprehension is understandable. It's natural. And so when we think about comparisons, telehealth versus an in-person encounter, I think in some respects it's a false comparison, because most often what we're really talking about is a telehealth solution versus treatment as usual, which in many of these cases would be no treatment at all. So in the instance of Dr. Lambert being on our inpatient service, she's providing really high quality care with really high satisfaction. If she's not there, she doesn't treat anybody. And so that, I think, is the real comparison here. And so when we think about it, I think you can't take that personal relationship out of that equation, because it's primary, and it has to be there. And if it's not there, no good care can follow. I can certainly appreciate, as somebody who lives in a small rural community, like having those personal relationships, and you lose a little bit of that. You don't bump into your primary care provider at the grocery store, or you don't run into them on the street, or soccer practice and things like that. So you lose a little bit of that maybe community integration. And at the same time, when it's apples to apples or apples to oranges comparison, it's really a high quality service versus the absence of such. I think that's really where you see a lot of the benefit.
So Mike, I think that was a truly good question, and I'm going to try to reinforce that to Representative Hebert. I wish that Senator Ballant was still in the room in her role as Vice Chair of the Senate Education Committee. But when you wouldn't know it from this panel, but we have an aging demographic for our providers as well. And when you look forward to what is necessary to fill that retiring workforce, and when you look at other countries who have really done a good job with quality and containing costs, they have the exact opposite of what we have. Here in the US, we have one primary care doc out of every 3. The rest of the world has 2 primary care docs out of every 3. And I would challenge the legislature to make it a priority to bring in our institutions of higher education and really begin that conversation about how we can have more primary care providers, whether they be MDs, NPs, or PAs. We need them desperately.
My name is Richard Davis. What you're describing about telehealth, it's all institutional based and pretty much controlled by institutions, and it seems to me like we need to move away from that institutional model when we provide health care if we're really going to make any progress. And so what I'm wondering is, in terms of telehealth, have you considered switching looking at it from a different perspective and saying, maybe we should, there's a lot of people out there that will never leave their homes. I mean, a surprising number of agoraphobic people, people who, their medical condition is such that it's beyond an extreme hardship to just get to the doctor's office. So, and they already have a relationship with a provider. So have you ever considered using the telehealth tools to allow for a visit into somebody's home where there's a critical need? I mean, I hate to see all these changes just based on institutions when I think the majority of care needs to be provided in other places. So telehealth has the ability to facilitate that kind of change. So that's my.
Kevin, do you want to
Sure.
take that to start and I can tag from there?
Yeah, so I completely agree that there is a tremendous opportunity and we need to grow more in the delivery of telehealth to people's homes. Now, Vermont is ahead of the game in their new legislation, adding home visits to a location where telehealth is reimbursed by Medicaid and commercial insurers. And in the past, and in many states, that's not the case. So one is that helps. In addition, I think still the location of the service originating at an institution is still okay. That doesn't dictate that where the person with a need needs to be at that location. So we are certainly looking to expand our direct to home delivery of telehealth. We do some of that now, but I think, I kind of talked about acute care being our phase one. Phase two is really being much more robust in outpatient, direct to consumer, and direct to home, because I think that not only takes advantage of the relationship that was talked about in the last question, because your communication keeps you from having to travel. You have an established relationship often with the person on the other side of the telehealth encounter, and it occurs right where it makes the most sense for you as the patient in terms of satisfaction and actually probably health outcome. So I think we already are thinking that we're doing some of that already, and probably think our most robust area for that would be the inflammatory bowel disease example, where a lot of that care is delivered directly from a provider who, yes, is sitting in our hospital when it's happening, but is delivering it into the homes of his current ongoing customers, and only occasionally is it identified through that there's an additional advantage of a future appointment that involves travel. I think that's a great point.
Sure.
Do we have other public comments or questions?
Just to add a quick thought, that there is an upcoming demographic where that is the preferred mode of communication and care delivery. So it's something that we look to make sure is considered patient preference, and also ensuring quality delivery.
Hi, I'm Fred Bruley. I guess I don't have to stand. I'm a parent of a young woman, 34 years old, with a developmental disability. I also sit on the Developmental Disabilities Council in Vermont. I'm very pleased that this is here, so I didn't have to travel 2 hours to get to it. I just want to, I don't really have a question as more than just a comment, that I just want to make sure that the Green Mountain Care Board is keeping people with developmental disabilities in mind as they move forward and managing of Medicare. My daughter is currently receives long-term supports and services through the Medicare funding, and she and many of her friends are dependent on that model going forward. And so I just wanted to put that up there. So thank you very much.
So thank you, and what we're really focused on as we move towards this new delivery system is making sure that the care for your daughter is across the whole curriculum. And so hopefully it will be better care, but it will depend. Other questions or comments? Would any member of the board like to offer anything?
Yeah, I
Jess.
just wanted to say thank you. This has been really enlightening. You know, I've been hearing a lot about telemedicine and the potential there, so this has been really helpful. And the questions from the audience were fantastic. So many of you had similar questions as I did, and so thank you for asking them because I got the answers.
So I too would like to thank the panel. I know that your days are very, very busy, and you took the time to spend it with us this afternoon, and it's been very, very helpful. And you really are doing yeoman's work, and keep it up. And with that, I'd also like to thank the Brattleboro community. We really enjoyed our time here today. And so before we close, is there any old business to come before the board? Seeing none, is there any new business to come before the board? Seeing none, would somebody like to make a motion to adjourn?
I'll make a motion to adjourn.
I'll second.
So it's been moved and seconded to adjourn. All those in favor say aye.
Aye.
Any opposed? Thank you very much.
Thank you.
Well, I have a